Thank you, New Smile, for this invitation and support. And thank you to you in the audience who are taking your precious evening time to hear me talk about science of bioactive ceramics for pediatric dentistry. You probably don't know me, but I'm an engineer. I've been working in dental materials for 35 years. The last 2 decades I've spent focused on bioactive cements, and that's going to be what I talk about tonight. I also volunteer for the ADA about standards. I've done some research, written some articles. I'm a reviewer, and I have some patents that are pertinent to our discussion tonight. I've contributed chapters to dental materials books and to 3 books that have focused on endodontics and vital pulp therapy. This year, I just published a book on all the uses of ceramics in dentistry, some of which might surprise you. I should disclose to you that I was the person that commercialized the manufacture of White MTA for dent supply way back. After that, I invented several bioactive materials, one of which we'll discuss tonight, and I have 6 patents on bioactive dental cements, which are shown here. What I would like to discuss today with you is 3 things. Some definitions for things that I'll use throughout my talk, some popular bioactive products, and give you some ideas to think about for how you choose a bioactive dental cement for use in pediatric dentistry. So when it comes to definitions, materials in our world are either ceramic, organic, or metallic. And the materials that we use in dentistry and medicine are a subset of that we call biomaterials. Now, what I want to focus on tonight is really ceramic materials, which can be crystalline, glass, or combinations thereof. And I'm showing you some examples of ceramics in your life. The most important is undoubtedly the electronic ceramics that make this webinar possible and a lot of equipment that you use. But let's even further focus on the bioceramics, which can also be crystalline, glass, or combinations thereof. But bioceramics includes a lot of materials. It includes zirconia, alumina, inert materials, radiopaque materials, bioactive and resorbable bone grafts. But we will focus tonight on bioactive cements that give you some advantages in treating pediatric problems. So bioceramics is a big area, but we only look at a small slice of it tonight of the bioactive materials, which are generally considered to be hydroxyapatite, calcium hydroxide, bioglasses, but we're going to emphasize the calcium cements. Let's talk about bioactivity. It's a much used term these days, but I mean bioactivity is the formation of hydroxyapatite on the surface of a material. So if we start with a healthy tooth and then it becomes carious and you have to treat it, you're going to ideally insert some bioactive material in contact with the pulp if you're doing a pulpotomy, and then cover that over with some restorative material. But let's focus on this little area here of the contact of the pulp material with your bioactive. And what I'm trying to show here is that bioactivity, you form HA on the surface in a cross section of a root end that was filled with a bioactive ceramic. You can see a layer of white HA crystals that formed on the surface. Now, if we look down onto the surface, we'd see the HA crystals that are like here, they look like rosettes. So in a simple way, bioactivity is a cloaking device. It is going to hide the foreign body or the foreign material, which is the cement product, and cause precipitation of HA on the surface, which looks more natural to the body. And you're going to eliminate some degree of the foreign body response and help to support the healing processes. To get bioactivity, you've got to have 3 ions, and that's calcium, phosphate, and hydroxide ions. The phosphate comes from body fluids. The bioactive material has to supply the calcium and the hydroxide. And then again, you get these precipitates that look like little flowers on the surface. There are a lot of bioactivities out there, bioactive ceramics. They may look alike because most of them are powders or granules, but they can behave differently. And I want to emphasize that in a few slides later on tonight. And we're just going to focus, instead of the bioactive glasses or something, we just want to look at the calcium cements because they've been so successful. And they've been successful because when you put them in, mix them with water, they harden and they aren't resorbed by the body. And they've been very successful in pediatric dentistry and all vital pulp therapy. And they've really changed things for the endodontic procedures that are, for endodontists. What these bioactive cements do is enable you to treat the continuum of pulpal inflammation because they are going to provide this protection by forming this hydroxyapatite layer. So, what makes these calcium cements bioactive? They react with water, they form this calcium hydroxide, you get this high pH that causes the hydroxyapatite layer to form, and you get some concomitant antimicrobial effects because of the high pH. So, let's just look at, for an example, at one of these ceramic materials. It's called tricalcium silicate. You add water to it, it hydrates. It's partly amorphous. But another reaction product is calcium hydroxide. And chemically, this is how it is written out. So this is really great with the silicate cements, but it also occurs with the calcium aluminate cements. They're related, and here are a couple of examples about how these other cement phases work. Let's look at some popular bioactive products to bring this into focus for you. But first, we have to learn a little bit about the nomenclature. People that first hear about these bioactive cements probably hear about them as mineral trioxide aggregate. And that's a made-up name. It's not a scientific or a chemical name, so it can have lots of different meanings. Then things are even more complicated if you're trying to learn about these bioactive materials, because in the dental literature, there's all sorts of acronyms that are used. They've called it Portland cement, all sorts of things here. But of course, my least favorite term is bioceramics, because as I've just shown you with my pie charts, bioceramics includes a lot more than just these cements. So let's add a little material science to this, and all the products that I showed you on the previous slide and on a few coming up, they're all based on the calcium silicate cements with either the ceramic phase of tri or dicalcium silicate. They're often manufactured together. Manufacturers usually add minor amounts of some other calcium cement phases, and they may add some calcium compounds to it because calcium sounds good because we're thinking about forming bone. The materials also contain significant amounts of inert radiopaque bioceramic powders. So again, back to the pie chart, we're combining both the bioactive cements with an inert bioceramic. There are a lot of products that include the name MTA, but let me tell you that these products don't all have the same formula. And then there are a lot of other product names that are out there that do include the same calcium silicate cement, but have the unique formulas that those manufacturers have created. Let's go back to the beginning though. The first product, it was called White MTA, mineral trioxide aggregate, and it had about 73% cement. And it had about 22% of bismuth oxide, which was used to make it radiopaque, and a little bit of calcium sulfate. As I said, manufacturers add other calcium powders for various reasons. This product was mixed with water. It was criticized for a number of reasons, but mostly it tended to be a little bit coarse, and mixing with water didn't give you the best handling. Biodentin, with which I'm sure many people are familiar, also had a lot of the tricalcium and dicalcium silicate cement, but very little of a material to give it radiopacity. They added a lot of this calcium carbonate product. And interesting, they innovated and it's made a water-based solution, then added the process of triturating the powder and liquid together to get some good mixing. I could show you a lot of other formulas, but the whole point of this is that you have to balance the amount of cement that's in a formula with the amount of radiopaque powder and other ceramic powders that a manufacturer wants to add. Plus, there's a consideration of what liquid are you going to offer with that for whatever reason you want. So for instance, this is important that will help us later on. The liquids can be water-based for the two-component products, but we're going to talk about an organic liquid that is present in the paste or the putties that we're going to focus on tonight. So as I said, we've gone from powder water to powdered gel, and now we'll focus tonight on some putty products. But before we do, let's just have a little thought process about how do bioactive cements set. If you take a powder and a liquid cement product and you mix them, a water-based liquid, they're going to start setting immediately, and you can get some fast-setting products that way. The putty products are really a unique thing in dentistry among dental materials because they only start setting when they're in contact with the body fluids. And then the bioactivity can occur. So let's just have a little visual on this. You take a bioactive cement, which consists of a ceramic powder dispersed in an organic liquid. You place it in, for instance, in pulpal contact. So you've got the body fluids in contact with the surface of the cement. And what happens is that the bioactive cement paste will eventually set because water has diffused in, the organic liquid has diffused out, and eventually you get this layer of hydroxyapatite that forms on the surface. So with that background, let's talk about what one can think about to choose a bioactive material for pediatric dentistry. There are a lot of things that you might be thinking about, and we're going to talk about all of these briefly. To do that, I decided to simplify this in a short period of time with the ever popular putties, and I chose to look at Vista Apex Regen, which is also sold as EndoDirect Endoceramic. There is a Brasseler product that is made by another company for Brasseler called EndoSequence BC Pediatric. And there you have it. I don't even like that BC right there. And then there's the New Smile Neo Putty. Of these three putties, only the Neo Putty has indicated pulpotomies on their instructions for use. So that is useful for a pediatric dentist. And when I looked at the shelf life of these putty products, I noted that the Neo Putty has a 3-year shelf life, which you can attribute to several characteristics, including its nice aluminum can. But the shelf life is also determined because of the outer packaging, the inner packaging, and even the organic liquid that's present in the material. Okay, let's talk about composition. If you go to the safety data sheet for these materials, you can find out a lot of information that can be useful in your selection. For instance, whoops, uh, sorry. Oh my. That two of these products have calcium silicate cement. And that's important for something I'll show you later related to hydroxyapatite and bioactivity. The Vista Apex and the EndoDirect materials do not, but they do have some amount of calcium aluminate cement. So does Neoputty. But I want you to look at this because I told you before the original products had like 70 to 80% cement in them, and this is a much lower amount of cement. All three products, of course, have a radiopacifier, not the original bismuth oxide, but zirconia is very popular, and so is tantalum oxide. The other products disclose that they have calcium compounds in them, but the Vista Apex also says they might have some alumina or silica in them for reasons that intrigue me because of cement chemistry. But the Vista Apex on their website say that they had bioglass in their material, but that was not disclosed, and nor was it discernible when X-ray diffraction was performed to confirm some of these compounds being present. So this was courtesy of New Smile, and they did show that the cements that they say are the cements you get, and same for the radiopaque. But there was no evidence of a bioglass being present. So, okay, now we know something about the powder compositions, but as I said, you got to have powder and liquid in this system. These putties have undisclosed organic liquids that are in there, but they're roughly at about 20% because that makes for a nice thick putty that you might like to use. These liquids are not required to be disclosed on an SDS sheet because they're not hazardous. But I want you to realize that the liquids do affect the handling, setting, and the shelf life, as do these thickeners. So we have really evolved from hand mixing to trituration and these pre-mixed pastes. So when you think about handling of these materials, two things. We also have new packaging. So we've got these syringes, which are very popular. We've gotten away from the individual sachets where you can't choose the amount of material like you can with a putty. Or you can choose the amount with some of these bulk bottles also. But handling a putty is easy and fast to dispense. And when I examined all three of these putties, I noticed that the Vista Apex and Endo Direct materials, they were the most firm. And they were more firm at the beginning, which indicated to me a non-uniformity that I don't like and can be a little disconcerting for clinical placement. The Brasseler material was much more conforming. It was the softest of these three materials. Well, of course, you'll say I'm prejudiced, but I did like the handling of the Neo Putty because it would conform to the plugger and deform so you could place it easily, but it wasn't sticky as people worry about with composites. And again, the handling here depends on powder particle sizes and the organic liquid that's included. Another thing that you might be thinking about is how fast do these set? Well, there is an ISO standard for testing, and you can measure the setting time with a sort of crude apparatus, but it requires about a gram of material. So the setting times when we measure them in that way and the manufacturers disclose them are upwards of an hour. And when New Smile tested them for me with their equipment, they couldn't even confirm this. It's a difficult test to get accurately for long setting materials. But if you are using only a tenth of a gram, let me reassure you that the diffusion of the water into a very small material on a pulpotomy is going to go much faster than the prescribed ISO testing data. But do these setting times really matter clinically? Because you're going to place the material and then you've got to put a restorative over it. So here's one thing that I want to bring up about those cements. I'm not so happy about the formation of HA for either its speed or, well, for its speed, if you don't have a pH higher than 12. So the Vista Apex material had a lower pH, and let me show you that magnified, of around 9 to 10. So that isn't as encouraging for bioactivity as when the pH is higher. So the response in vivo can be slower. People have talked about MTA as discoloring. All you have to do is buy a product that doesn't have bismuth oxide. And we'll have to talk a little bit about chemistry, but I want to show you some pictures. If you have bismuth compounds right here, and I included tantalum oxide, you expose them to either sunlight or sodium hypochlorite, these materials will darken. Now, the tantalum oxide didn't discolor, but all these bismuth compounds did. And the reason is that the valence of the bismuth oxide changes from +3 to +5, and that changes the color. So avoid those products. Radiopacity. These putties that I'm showing you tonight all have significant radiopacity. It's only required to be about 3 millimeters of equivalent aluminum for root canal sealers. And you can see there are quite high values that are present in all these materials. Here's another thought experiment. These calcium silicate and aluminum aluminate cements really have very minimal expansion. And this contrasts with what we worry about with shrinkage of composites. The amount of expansion is less than 1%. Some materials have clay thickeners in there which quickly absorb water and can expand, but that only happens before the setting is complete. I'm not too wild about that phenomena because it may lead to porosity. And people publish a lot of papers about bonding, but the funny thing about this to me is, well, this is not funny when my thing doesn't work, that the bonding is going to be minimal between a composite and a bioactive cement or a bioactive cement and the surrounding dentin, because you want to put a bioactive cement to heal and seal the pulp chamber, but these materials are not really designed to be bond to the restorative material. You use the restorative over it, which must bond to the teeth because you want the restorative to stay in place, to not break, and to prevent bacterial ingress. So the lack of shrinkage is great. And bonding, I can't get excited about some of the data about that compared to restorative materials, which need to have a bonding strength of about 20 to 30 megapascals. Now, when it comes to choosing a dental material, you may want to have literature support so that people have shown you that the material works. And neoputty, there are 23 publications on it, 7 of which are clinical trials, 2 case reports, and then several other articles that are on in vitro tests. But I didn't find any articles on the other 2 putties. And just as a note, in my EndNote library of references, there are 84 other articles that I've read about neoputty that at least mention it peripherally or in some way they've tested it. So you don't need to see the whole list, but it's there. I'm getting to the end here. The biocompatibility and clinical response, I glided over that because that could be a full day lecture. But there are lots of articles that consider the calcium silicate cements that we're talking about to be the gold standard for vital pulp therapy in either primary or permanent teeth. And here's a list of some recent ones that make that statement, but it could go on and on. So you'll see some marvelous clinical responses with Dr. Ruck when he's coming up. So, in summary, the calcium ceramic cements are really great for vital pulp therapy because, very surprisingly, they're bioactive, form this HA layer, helps healing. There are a lot of products out there. I think you should think seriously and carefully about how you buy a product. And the putties are very popular, but they're not all the same. So I gave you a laundry list of how you might want to choose things, and I hope this will be helpful to you in the future, thinking about not just bioactive materials, but choosing any other dental material for your practice. Now I have the great pleasure of turning it over to Dr. Ruck, who's going to show you some clinical results and will be much more exciting than this. But I do thank you all for your time. It was very kind of you to be here tonight. And with that, I'll stop sharing, and questions will be at the end, as we said.
Thanks, Dr. Primus. That was awesome. I got really excited when I heard that she was comboing with this because she's like that the like the OG with all this stuff. It's rad. I remember in residency when we had a packet of Pro Root and it was so like it was new and it was expensive, so you had to like partition. It's like, oh yeah, this is the future. And now look where we are now. So that's kind of crazy, man. It's just rad. Let's see, let me share my screen and then share. That was awesome. Okay, can everyone see my screen? Yeah. Okay, cool beans. Well, thanks, guys. I appreciate it. I'm gonna go into the second part where we're gonna kind of talk about clinical applications, and I'll be mindful of time. So what we're gonna do is kind of talk about everything that we reviewed in the first half, and then kind of look at the clinical applications of it. And I love this first slide. This is something. This is some of my pulpotomies and something I do a lot with neo putty, and then on top of it, a high viscosity glass ionomer cement that I almost use as like a little core buildup. Um, what Dr. Primus just said is you can't really bond to these di and tricalcium silicates, so we're going to kind of fill that space and then prepare it over with a full coverage restoration or a composite on top of that. So just a disclosure, New Smile kind of helps us put these presentations on. And there, if I have any image that wasn't mine, I credit that doctor for doing that. This is just a little bit about me. I have 2 little wild kids who still aren't asleep yet that I could still hear. It's almost 9 o'clock here. Winston and Carolina, and that's my wonderful wife Magdalena, who is watching them while I get to do these wonderful things. So I appreciate that. I work at Cincinnati Children's Hospital 4 days out of the week in a private office. That's kind of our crew. We have a great group of faculty and staff doctors. Some of them you might recognize. And then I have a goofy Instagram and YouTube channel that has a bunch of examples of just videos that I make for the dental residents. This is the private office that I work at every Thursday, so I'm there tomorrow. Dr. Marie Callan, she's amazing. I've been with her for a little bit over a year now. Just trying to just keep my hands in all things. I really love New Smile, and I appreciate the time that they get to put on these webinars. One thing that I just actually like to talk about with New Smile as a company is the people that work there actually care about the products that they sell, and they care about you being successful with those products. And I can't say that enough. Um, as far as if you ever have an issue with a product, a problem, you want hands-on training with a doc in nearby, they're really good at hooking you up with clinicians close by or just giving you some personal feedback on certain products if you're having a hard time implementing them into your practice. So I do think New Smile is a company that cares about you as a provider and then also cares about the products that you're using to be successful in your practice. So just some overview and objectives. The four things. So now we're going to kind of implement everything that I just talked about, and then understand how the ditricalcium silicates actually respond to pulpal inflammation and how they kind of differ from previous current standards like ferric sulfate, former creosol, and then look at how that clinical application is performed when we're doing pulpotomies or revascularizations or even indirect pulp therapy in the dental clinic. I just like to put a little code right there. Newsfile puts all of these YouTube videos online, and it's a really cool resource for you guys to check out if you want to listen to other people's talks. It's just really nice. I actually refer our dental residents to there. Same thing with like the Sewin or some of the other products. All right, so we're going to get into MTA or not MTA, ditricalcium silicate base liners and pulp. I got to edit this now. Liners. I joke that MTA is now like the word Kleenex or like a pop. Like it's not really. I'm the same way when I talk to our doctors. Ditricalcium silicates. So we're gonna get into MTA or modified liners and then MTA putties. And so our indications for a product like Neo Liner, so something that has resin in it, would be anytime we do indirect pulp caps. And then anytime that we have vital pulp tissue, so that would be apexogenesis, direct pulp capping, partial pulpotomies, full pulpotomies, that's when we're going to use our pure ditricalcium silicates that don't have any resin-based products in them. This is just something that I got interested in when I started coming back to work. And I noticed that there was this large change in pediatric dentistry around like 2015, where we weren't doing as many pulpotomies. And now with these products, it blows my mind what you can get away with vital pulp tissues because their ability to actually heal pulpal inflammation. So this is just a study that I did when I first came back just to look at our program's usage and our utilization of indirect pulp therapy has completely flip-flopped with our vital pulps. So this is the group of publications out of Maryland from Jim Cole and then Vineet. They've come out with these really great. I forget when the first one came out, but it's a series of publications on vital pulp therapy, non-vital pulp therapy. Fairly recently, and I have it referenced in here, they came out with vital pulp therapy for permanent teeth as well. And one interesting thing that has kind of changed since I was a resident is that now these ditricalcium silicates are really the gold standard for therapy because we have more long-term clinical studies that are past 12 months. So we're going into the 24 months where your ditricalcium silicates are actually outlasting these historical medications like ferric sulfate and former creosol. And that's because we're actually medically and biologically treating the pulp. We're not just putting or fixating the pulp like with former creosol, and we're not just coagulating the tissue with ferric sulfate. We're actually inducing pulpal healing. And so you think about, like I was in the operating room today and I saw some young ones. So if I'm doing that pulpotomy on a 2-year-old, well, I want that has to last me a lot longer than just a year or two. So we're getting really good outcomes, long-term outcomes with our ditricalcium silicates. This is just some recent research. Dr. Primus put a lot of good articles in Neo Putty. And this was just a study that compared it to former creosol. And what's really interesting now is Saltan, who was the distributor for Buckley's former creosol, actually stopped distributing in the United States. And now we're kind of left with some other products that are pretty much just pure former creosol. So Buckley's former creosol was already a dilution that you were recommended to do a 1 to 5 dilution on top of that. So a lot of providers now, if they're using these other products, are using a higher concentration of formaldehyde and creosol. So, you're probably getting an acceleration of these resorptive effects from the inflammation that's left in these tissues. Or one, they're also getting a higher dose of formaldehyde. So just something to think about if you're still using formicreosol and you're not doing a self dilution, is that the level of formaldehyde in creosol is even higher than what you'd have in Buckley's. And then looking at our MTA products, Neo MTA, compared to ferric sulfate, again, these long-term studies are showing that your MTA, your ditricalcium silicate products like Neoputty are going to win every time because we're biologically treating the pulp. Alex told me I missed it. We had these back and forth emails, and she was like, "Oh," and I wrote this long thing, and she just asked me if I was okay talking about this. I totally misunderstood, but I actually kept this because what's there, why are these now the gold standard? Well, I just in one word that I outlined all the way up in this ridiculous paragraph that I wrote in the is that you get true pulpal healing, where these bioceramic materials, a very small section, these ditricalcium silicates are actually able to address pulpal inflammation. So we'll kind of get to that, but what I really want to spend a little small time on is this inflammation, and then we'll kind of get to cases. So we talked about formicreosol and ferric sulfate, that they don't really address the underlying causative of a reversible or even a irreversible pulpitis. And that is, it's an immune response, which kind of blows your mind, right? You think about this tiny pulp cell tissues. What's going on is a carious process that has all these inflammatory mediators and then local immune cells. It's almost like an innate immune response. And then you have these odontoblasts that are localized to the dentin, and you have these sentient immune cells that are able to generate reparative dentin. How Dr. Primus was talking about, it's almost kind of ninjas its way in there and lays a layer of hydroxyapatite crystals that the body can then view as more bioappropriate. So when we talk about those stimuli, we have our reactive dentin and then reparative dentin. You have your more mild stimulus, and this is me thinking about those deep carious tissues. Again, I was in the operating room today and I had a really large, took out 1 permanent molar, but we had 3 that we did indirect pulp therapy on with neoliner. And that is those areas where I'm not concerned that there's a pulp exposure, but I want to put some medicament down that's going to promote that tertiary dentin healing that is reactive, and those odontoblasts are localized. And then we have our deeper stimuli like our pulpotomies or traumas or things like that, where we actually need to recruit dentin like our stem cells that can morphodifferentiate into odontoblast like cells, and then kind of make this mishmash of reparative dentin. So again, our reactionary dentin to like a mild stimuli is very well formed and similar to dentin, where our reparative dentin is actually kind of, it's the way I think about when I do regenerative endodontics, is it's kind of like dentin, just like that's kind of like the root of the tooth. And it's not as well differentiated on a slide when you're taking a look at it, but it kind of makes dentin like materials. And then when we get into our physical properties, so Dr. Primus is talking about this, but how do we translate that inflammation and that healing process to then the products that we select for a ditricalcium silicate? This is a great study from 2022 that looks at different medicaments, calcium hydroxide based, bioceramic based, resin monomer based. And what you're really looking at, and Dr. Primus talked about this, is pH change, water absorption, and the cumulative calcium ion release. Well, why is that important? And then this is looking at your more pure products like your neoputties or things that aren't as adulterated. They're going to give a higher degree of calcium release than things that have a lot of resin-based product in it. And then what's really interesting, if you look at your calcium hydroxide products like Limelight, that isn't giving off pretty much any calcium release, which is kind of interesting. Okay, so again, what do we need in the bioactive material that translates into our clinical outcome? Well, that degree of proliferation in calcium actually helps with cell proliferation, and it's essential to that hard tissue pulp cells. And then, like Dr. Primus was talking about, the alkalinity is actually very important in these products. They all look the same, but the different physical and chemical properties are important to the clinical aspect of it as well, because that alkalinity is directly related to our ability, that bacterial cyto effect, but also promoting tissue growth factors and the healing of that area. And then we want a product that doesn't dissolve readily in water, like calcium hydroxide, that leaves little tunnels, and then we get failure of that medicament. So when we look at our comparison between calcium hydroxide and MTA, MTA is going to win out every time, because one, it does a better job at sealing, in that physical interaction between the two surfaces. It's also less cytotoxic and does a better job at causing cell growth in reparative dentin and regeneration. So whether when I was in dental school, you can throw your dicalvitribond in the trash can, and then you can also throw your calcium hydroxide based products as well, in starting to select. Again, it's just the evolution of these materials as they become better, and we understand that a little better. So getting into specific products, we have again our pure neo putty, like Dr. Primus was talking about. It is a putty based material in a organic liquid. And then we have a di-tricalcium silicate, or neoliner, that has resin in it. So we're going to use this in our times where we get direct pulp exposure. And then this is just going to be in our areas of indirect pulp therapy. One thing that I always want to point out with neoliner is that in the IFUs, it says that you have to bond prior to placing. And I believe, and correct me if I'm wrong, but that was just to get the product through, from a material science standpoint. But I put it, you use it just like you would use dicalvitribond or Theracal LC. It's going directly over those deeper areas, so you don't have to etch and bond prior to its placement. You place it less than a millimeter thick, and then you etch, bond, restore over those areas. Another interesting thing when you look at competitor-based products is some of them say that you can use direct pulp capping. Well, anything with resonance, remember, our purple cells are cytotoxic to monomers. So when you look at these nuts and bolts studies that look at resin-based products like Theracal that are directly placed over pulp, that they find that unpolymerized resin monomer is cytotoxic to those pulpal fibroblasts. So I would stay away from any vital pulp tissue with these materials. Again, calcium release is important to these products. Neoliner has a high degree of calcium ion release, and this is New Smile, and this is internal research that's here. Okay, so when we look at clinical applications of this, the thing that I really love about this product is it comes with a sealant tip, and you can just put it I believe it's a 22 gauge, is you can just put it exactly where it needs to go. It's so easy to place. I love it. We use it in all of our operating rooms now. All the docs love to use it, because it's so easy to use, and it translates into what Dr. Primus is saying. Is that you're not getting any of that medicament on your margins, so you can get a good composite bond. Here is an old amalgam that we took out, and again, we want to layer that floor where that pulpal surface is hitting, so we're not etching directly over that, causing post-operative sensitivity. Every time I see these on my schedule, this makes your butt cheeks tight, and because that pulp's hanging out right there. Well, what are we going to do? Patient's asymptomatic. Again, a lot of this and what you're going to use and select is based off the symptomology of the patient and the level of caries. Selective caries retention, plenty of research that shows we can use affected dentin or leave that behind as long as we get a good marginal seal. And the alkalinity of this product, and also the degree of calcium ion release, is going to help with that tertiary dentin formation, but also act as an antibacterial to that product as well. My boy, I always have to give a shout out. This isn't Paul's case, but Paul taught me how to do this. Dr. Paul, he's the man. And this is just using a smooth orthodontic band. Again, I'm covering up that area where I'm concerned about pulpal exposure. And then I build that medicament up, and we can kind of see that orthodontic band hanging out there for these molar hypomineralized teeth. When we get, and sorry, I apologize, I'm speed running through this just for time, but I have these are all on the YouTube as well. The YouTube, I just sounded like an old man saying that. But when we do vital pulp therapy, these again are going to be our pyridine tricalcium silicates like neoputty. So Dr. Primus kind of got into this, but this is kind of how our hydraulic calcium silicates, the water, and this is why I like to focus on this, or the body fluids of the tissues is what causes that chemical reaction. So I always like to, and I will show this for a second, but I always like to make sure I'm using a moist cotton pellet. You don't want to look inside that tooth and there's not zero either a little pool of heme or you're not using a moist pledget. And this is just showing bleeding for a second where that's a little too much pulpal bleeding before we're putting that material over. And I'll finish up in just a second. I apologize. And then make sure we have time for questions. But what you really have to make sure when you're switching from formicrete or ferric sulfate to these products is that we really have to understand what pulpal bleeding means in relation to the inflammation. I could put ferric sulfate or formicrete on a tooth and it's going to stop bleeding, but that doesn't mean that pulp is going to be successful and it's not going to fail. So we really need to understand the difference between that and then when we have to do other procedures like a pulpectomy or things like that because there's too much periapical inflammation. I love neoputty. It's so easy to place. I just roll it on the back of my glove and it comes with these very nice dispensers. And then once I remove my cotton pledgets, I really just take the neoputty off my glove and pack it into the tooth. But that's the level of heme that we would want to see for that. A little bit of pooling. It's not filling up. That's an appropriate amount of heme. And this is with my intraoral. That's a lot of neoputty. So I kind of probably used a little bit too much there. And then we're condensing it down with a moist cotton pledget. And then putting a glass ionomer cement over this to fill that area. And then that's just, you don't have to do that. That's just something that I like to do. If that kid's eating a Jolly Rancher or something that pulls that crown off, I know that my restorative material is still well sealed. And then just kind of showing my crown workflow. Again, one thing I'll show a few more slides too, but bleeding is so important when you're doing pulpotomies. So this was a tooth and you'll see we'll suction it and that heme is going to fill right up. So this tooth is too symptomatic. Maybe the parent was telling me, oh yeah, they've been waking up having spontaneous pain. So we really need to understand our diagnosis of reversible, irreversible pulpitis, symptomatic apical periodontitis. We have to understand those endodiagnoses so we can be successful. So we ended up doing a pulpectomy on this, and I just love it because it looks like a little hat. So that's an acceptable amount of heme. And then this is not with sodium hypochlorite. This is just with a moist cotton pellet that we're packing to get pressure hemostasis. And then what's really rad is we're saving so many of these kids from needing root canal therapy. I would say if you're getting into doing permanent molar pulpotomies, I would get some surgical length right angle slow speed burrs. I use a right angle surgical length number 4. It just lets you get farther down into that chamber and makes your life a little easier. But it's just so nice that you get continued apexification or apicogenesis, excuse me, without having to send these kids off to get a root canal. And this is again Vineet and James's recent publication that shows that these are totally clinically acceptable and they have this really nice workflow of what to do if you have a carious pulp exposure. This is one case from Dr. Matt Lucero, kind of demonstrating direct pulp cap or pulsar pulpotomy in these clinical situations. And then a full pulpotomy is a case that we did. And then I do a lot of endodontics and trauma. I love doing these. I would have just sent these kids to the endodontist previously. This is a young man that fractured this tooth. And what's really rad is this is the second time he fractured this. So imagine if the first time this kid had a full root canal and he fractured it again, well, then we would be doing a retreatment. So this is awesome because this is actually the tertiary layer. So So I just did another pulpotomy, and this young friend's doing wonderful. And then we do a lot of apexification and revascularization. So what's really nice about these di and tricalcium silicates is the stimulation of apex generation of this tooth. And I have another lecture on that if anyone's curious, where you stimulate bleeding, place a collagen barrier, and then place your di and tricalcium silicate. Well, here's this young man at follow-up, and they're asymptomatic, and we can see that there's continued apical morphodifferentiation. And then this is my last favorite story. These are my two dogs waffling maple syrup. We got a pulp exposure here because he's a wild man. And then we just did a little neoputty pulpotomy. So not tested on animals, but tested on this animal. And he's still a happy guy. It's still in there. So thank you guys. I know that was a speed run, but I have a lot of cases, and if anyone has questions, I'd be more than happy to share my whole presentation with you. I don't give whatever y'all want.
Awesome. Thank you so much, guys. So it is 7:56 or, 5 minutes till ending or whatever. But I think Dr. Ruck and Dr. Primus are happy to stick around for a little bit longer. If you want to ask any more questions. We don't have any questions in the question box as of this moment. So ask away though. And but if anyone needs to leave and get to whatever it is they're supposed to be getting to, you'll still get your full hour of CE credit. So stick around for questions if you want. If not, definitely be on the lookout for that survey from Nicole or Zoe. And then once you fill that out, send it back. They will get your CE to you within 24 to 48 hours. Look in your junk mailbox or whatever it is. Um, and and then if you can't find it, then reach out to us. Um, let's see. Still no questions. Did somebody, let's see, who raises their hand? Oh, I have a question. Ding ding. Yay. Uh, do you recommend 35% H2O2 superoxyl for primary teeth as a cotton pellet?
I wouldn't. I You don't really need. So this is I'm guessing they're asking for hemostasis. You don't really have to use any sort of additional like tertiary product to get hemostasis. You don't need to use superoxyl. You could use, like, if you look at Jim and Vinit's research, there's really nothing that's going to give you a better outcome. You could use like 3% sodium hypochlorite. If you look at the American Association of Endodontics, their vital pulp therapy, they do recommend placing sodium hypochlorite, but that's for like permanent molar pulpotomies. I just follow the AE. But yeah, superoxyl, I mean, I don't necessarily think you would need that. What I would be worried about placing superoxyl, because we do a lot of internal bleaching, is that there is a slight increased risk for internal resorption as that superoxyl can penetrate into those tubules. So I'd be a little worried about a potential for resorption, internal resorption, if you're placing superoxyl pellets inside the pulp chamber, the vital pulp chamber. So I would
Right.
say I wouldn't do it. I would just use, if you want to use something, I would do like a 3% sodium hypochlorite, which you don't even need to do because the alkalinity, like Dr. Primus was saying, I keep saying her name. I apologize, doctor. Of the material is 12. So in sodium hypochlorite, the alkalinity of that is also 12. So it's kind of like you don't really have to, but you could use a sodium hypochlorite pellet like 3% if you wanted to.
Right. Uh, we do have somebody raise their hand. Dr. Pasternak, I see you raising your hand. If you have a question, if you could put it in the Q&A, that's at the bottom of the screen, we will answer your question there. Um, Otherwise, maybe you're just waving at us, so hi. Um, any other questions I know these two amazing doctors probably answered all the questions you have about bioceramics and more. Um, but they're always here to answer more questions if you guys have anything come up. Um, we'll wait around a couple more minutes. Um, if you're in the Houston area, hope you stay safe and warm this weekend. Some ice and stuff on the road. If you're trying to travel to Texas, good luck. Um, like Dr. Ruck said, he's always available. He loves this stuff, I could tell. And he is always available to answer questions about all of these about bioceramics and all of our products. So if you have any questions about any of them, definitely shoot them his way. Um, get Dr. Primus's book if you want to know all the answers to all the questions about bioceramics. Oh, we have another question. What are the differences with neoliner versus limelight?
So that's a great question. So let me I don't know if I can back up on my presentation, but so neoliner is a diene tricalcium silicate based product that has resin in it. Limelight is a calcium hydroxide product with resin in it. So if you look at that 2022 study, what I want to point out is that limelight is not really going to get what you want from a product that your goal is to get the benefits of a diene tricalcium silicate because it is a calcium hydroxide. And what I really want to show is the pH value changes. So this is 90 days, and this is kind of what Dr. Primus was talking about with some of these other products. Is it really does matter if you have a product that has a sustained alkaline pH, and also when you look at the degree of calcium ion release, because we talked about how that's important in the tertiary dentin formation. Limelight is all the way down here at the bottom. So we're not even getting a higher degree of calcium ion release similar with its pH change. So if you're going to use that product, I would think about using a product that's more of a diene tricalcium silicate. I think we've evolved past the need to use calcium hydroxide because there's better products available. And neoliner would fall into that as far as a product that is calcium silicate base. It's going to give you the benefits of those materials. That's going to kind of beat out a calcium hydroxide based product.
Awesome. Now that we have two more questions. If you use glass ionomer cement for crowns, do you recommend using the same product as your core buildup?
No, you don't have to. If you think about it, like the reason why I do that, it's just to really fill up the area. So I'm trying to go back to that. I've used Vitribond. I've used Voco makes a really nice product. I don't know why it's called. Oh man, it's out of my brain. But it's a glass ionomer. I'm gonna remember it in like 2 seconds. But it's just it comes in a syringe and you could fill the product up and polymerize it. If I'm doing a lot of pulpotomies like these three, I'll just use one carpule of like GC Equia Forte, like a high viscosity glass ionomer cement. If I'm just doing one, I'll do like a double hit of neoliner. I mean, no, that's an expensive pulpotomy. I'll use Vitribond. Oh man, what's that? That's gonna kill me because I use it every day. That the Voco, it's a Voco product and it comes in a syringe, and it's unit dose and it's an RMGI. But they did this really nice study. You can kind of put whatever you want over your diene tricalcium silicate pulpotomies. I would just be mindful of if you're using an RMGI based cement and you're using like ZOE or things like that. If you have any resin in there, so just be kind of mindful. If you're using a pure glass ionomer cement, like a Keytac or a Fuji One, then it's not that big of a deal.
Right.
Kill me, I'm gonna look that
And
up.
another one. I currently use Neoputty, but people have been saying to change to Biodentin, especially for permanent pulpotomies. Is it better?
When I have looked at, and Dr. Primus might be able to answer it. When I've looked at all the nuts and bolts comparisons to Biodentine and neoputty, they're similar, and I could share some of those studies with you. Um, you're not going to get any difference in performance. So when you look at Biodentine, and they're di and tricalcium silicate based products. They add calcium carbonate, and there's an accelerant that's in the liquid. So as far as what you're getting out of it, there's, Biodentine, when you read all these studies, is what they compare a lot of these MTA products to. So if you look at the neoputty studies that they compare to Biodentine or MTA plus, you're not going to see a difference in those. There's not a difference in the gross alkalinity of it and in the biochemistry of it. You're not going to see a large difference using one or the other. I think the biggest thing when you start doing permanent molar pulpotomies, or is really understanding the underlying diagnosis of that inflammatory pulp tissue. And if you look at studies that there's even studies that look at symptomatic apical periodontitis and doing pulpotomies, and there's still a success rate, but it's 70%. But what that means to me is that if there's a continuum of reversible pulpitis, irreversible pulpitis, symptomatic apical periodontitis, it depends on where we're catching that tooth and the success outcome of the ability to the pulp to heal from that localized inflammation. But no, I think it's safe to say that, like Dr. Primus was saying, neoputty has now been studied enough to where it's in that A tier, as far as how people felt about Biodentine when it first came out.